and efficiently with appropriate regulatory oversight and in the best interests of our patients and our health system. As the innovation and investment in AI continues to grow, the medical profession must be prepared to lead this integration and not be led by it. And that's really the point of our session today. So this session will provide the AMA with an opportunity to identify areas for our advocacy and to provide members and delegates with a platform to understand and appreciate the current and future applications. I know our literacy in this area is low and it needs to be brought up very quickly. We don't have motions at the end of this session. I was told we don't need them, and in fact, I would like to thank Michael Bonning for putting one up last year, which I think has led to this session. The AMA has already started considering a policy on AI, but it's clear that we don't have the expertise as yet. But I'm very confident that after we've heard from our fantastic expert panel today, we'll be in a much better place to know where our advocacy directions are for the future. So we are privileged to have this panel together, and I'll introduce them one by one. We have 4 speakers, and at the end there will be time for questions, and please write them down and head to the microphones at the end. So our very first speaker is Professor Enrico Coira. He is a Professor of Medical Informatics and Director for the Centre for Health Informatics at Macquarie University. Having trained in medicine and with a computer science PhD in artificial intelligence, he has an extensive research background in both industry and academia. With an interest in exploring the different ways humans and technologies come together to support healthcare, he has a strong international research reputation for his work on digital health safety, decision support, and communication processes in biomedicine. Professor Coira will provide a broad overview of artificial intelligence in healthcare, including the current and potential future applications of AI that doctors can reasonably expect in Australia.
Good morning. I thought I would start the morning with a simple existential question, since we're all awake, which is there going to be a future for the professions? Will there still be medicine practiced as it is today in 100 years' time? And hopefully by the end of the talk you will have some optimism, but also you realise maybe that change is coming too. So we really are in the middle of a massive period of change. The last 3 or 4 years has seen enormous interest in AI across many industries, largely driven by huge investments from the big tech companies, billions and billions of dollars. When you do your Google search, when you look at your Facebook stream, all of that is driven by algorithms underpinned by AI. And so the enormous wealth that these technologies are generating for these companies has made them hungry to apply the technologies, not just in their own businesses, but elsewhere. So although I've been at this for a long time, I've never seen the tsunami of cash involved in AI as I have in the last couple of years. So in healthcare, the big news for the last few years really has been in imaging-based AI, in other words, ophthalmology, radiology, neural networks, deep learning, terms you've heard of maybe, really have transformed our capacity to interpret images at human or above human level in terms of accuracy. But it's not just in these diagnostic settings that AI is going to have an impact. Here's a paper, I think, from JAMA this week, looking at 20,000 patients for electronic record data. And they've managed just to phenotype 4 different subgroups of people who succumb to sepsis in hospital. Hopefully each of those subgroups will be treated differently and have different outcomes. So AI is not just about replicating or automating the work that we do, but it also has a role in scientific discovery. So that's pretty exciting. What's been interesting though is the rhetoric, which is that it's not AI enabling clinicians, it's AI versus MD. It's one or the other. You know, one is going to replace the other. And you know, for a while, if you went to Silicon Valley, you'd be hearing things about radiology is going to be replaced by machines. Dermatology, it's another image-based thing, will be replaced. Ophthalmology. So there's been a strong interest in replacing human expertise with these technologies, and it's been interesting to see how far that rhetoric has progressed. So just to give you a vocabulary for AI, and I'm not going to give you a tutorial on AI today, but the thing you most often will hear is deep learning. And deep learning is simply a set of technologies related to neural networks, which have been around for decades, but are fairly impressive, as I said, with image detection. They are just one small group of technologies within the larger group called machine learning. And machine learning are technologies which allow us to look at data and to discover patterns. So classic statistics is one element of that, but there are many other methods there too. And within that group, there are a whole other set of technologies that is more general AI. So the capacity to plan, to simulate, to foresee, to reason, to interact, to converse. All those things are separate technologies. So if you're thinking that deep learning is the thing, it's not. And finally, the area where I'm most interested in is the human-computer side. So how do we design systems that we can interact with in a way that's meaningful? So if you want to think about Siri or Alexa, they're very early examples of human-computer interaction with AI. So the state of the art, and this is probably the most important slide if you're thinking about where we're up to, is that today's AI is very good at doing the simple job it's been trained on and nothing else. So I can build a deep learning system to interpret TB nodules in a chest x-ray, and that's what it's going to be fantastic at. It'll be better than many radiologists at that task. It won't be good at anything else. So I've got a set of task-specific tools. The idea that we would have what's called AGI, or artificial general intelligence, this would be the Terminator or Skynet or whatever your favourite science fiction thing is a long way away. And probably the technologies to build that sort of general reasoning that would replace me is something that we haven't seen yet. When that happens really depends on when those discoveries happen, and that could be next week or that could be 50 years away. So just to give you a sense of where we are today with AI, here are some benchmark performances, and these are probably about 18 months old now. The red line here is human performance, and the blue line is AI's performing on the same task. And the first one is object detection, which you might call the Where's Wally task. This is being able to pick an image out of many other images. It's used, for example, for face recognition in crowds, other things. You can see that AI has far surpassed human capacity to detect objects in that way. Really amazing technology. This next one is to do with speech recognition. And again, you can see here AI equaling and probably starting to surpass, in some settings, human capacity to understand speech. However, there are strong limitations on this. This is really understanding one voice, maybe your phone talking to Siri, and even then there are problems. One of our teams back in Sydney, Macquarie, is looking at listening into conversations between patient and doctor in primary care with a view to helping populate the record electronically to save some of that typing. Can I tell you that listening to two people talk is an infinitely harder problem than listening to one? So there are things we do as humans to understand complex conversations that have yet to be solved. This next one here is question answering. In other words, what is the capital of Peru? Who is the Prime Minister of England? Thank you. And you can see here that AI is not bad at simple tasks, but still not getting there. The last one I show, just to give you a sense of comfort, is please explain what's going on in this image. And AI still struggles to explain what happens within a picture. Is this a cow or a Morris Minor? It's very easy to fool the AI just by rotating pictures, adding bits of noise to the picture, etc. So that requires knowledge and understanding of what's going on. It's not just a recognition task, it requires reasoning, which is why it doesn't go so well. Now, time is running on, so just to say, look, there are real problems still. So AI has been overhyped. For example, Watson for Oncology is something that was meant to transform treatment selection in oncology. That's not happened. There have been big challenges with business models. So here is an issue now with Babylon Health, which is a company in England which provides symptom checkers to help people decide whether or not to go and see a primary care physician or not. They've set up their own primary care practices in London attached to the app, and all the Healthy Well are now going to Babylon, leaving all the other primary care groups to deal with the elderly, the chronically ill, etc. And there have been real challenges to funding because of it. Should we trust AI? A big question. And I guess the answer is, do we trust other technologies? And the answer is, we already are very trusting as a species, aren't we? You know, we will do whatever the GPS says. You know, yes, we will trust cars to drive us, even maybe we shouldn't. And this is something which we call automation bias. In other words, humans have a willingness to trust what the technology does if it seems to be doing the right job. The same thing might happen, for example, if you're prescribing and you've got electronic decision support behind that. So we're very good at trusting technology even when we shouldn't, which is a challenge for us because the AI will be good or even great in some settings, but it will never be perfect. And this is the classic story with all digital health, which is that overall, for the population, it's going to reduce risks and harms, it's going to make things safer, but it will introduce new classes of harm along the way, iatrogenic harm. And so understanding what those new risks are is very important, and it's one of my interests. I thought I would just give you a one-slide summary of the sorts of things that clinicians need to think about as they use AI. And you're thinking, well, I don't use AI, but if you're using a prescribing package today with decision support in it, that 15 years ago would have been considered AI. So the first thing is to ask yourself, before you look at any recommendation, say, well, what do I think is going on? If you haven't got a view of what's going on, you're going to be prone to automation bias. You'll just do what you're told. You'll need to know, how good is this AI at this task? Has it been really trained to do this? Has it seen enough of this population to be robust? Do I understand how it came to that conclusion? Has it explained itself to me? If it's a neural net, it probably hasn't. Am I, as a clinician, aware of things that the system doesn't? Maybe I know more about the past history of the patient or the social circumstances. Maybe I have seen similar patients that the AI is unaware of. If I know extra, then I should bring that knowledge to the decision. Is the patient complicated in some way? Are they multimorbid? The AI probably hasn't seen that. It's just seen lots of single disease cases, and so it might be confounded. These are very standard things in terms of statistics, but they will be everyday challenges if you are using AI. So I thought I would talk a little bit about what's happening nationally. Compared to other countries, we are slow to I guess think through what AI might mean for us, and we're also slow to exploit it in some ways. In England, the NHS has spent over £1 billion on embedding AI technologies in the NHS services, for example. An enormous investment. If you look at other countries, for example in the US, the HMOs, health management organisations, have made huge investments, not just in data and analytics, but also AI. So when we go around the country, what we do have, though, is a lot of great people working in the area, but often in isolation. So what we have decided to do is to try and bring together academics, industry, providers, government, everybody who's got a stake in it, the colleges especially, where the future of the profession is at stake, to help us think through what this will mean for us, to help shape the policy agenda if we can, but also to drive essential research. And I think one of the things that we can do in Australia that probably other countries can't do is to focus on translation, to think not just about how good is the technology or how do we design a better TB interpreter, but what does this mean for my practice, for my workflow, for my patients? How does this embed into the work that I do routinely? They're hard questions, they're questions of implementation science, and they're not really being looked at anywhere. So just to give you a sense of the focus of the Alliance, at the moment we've got an interest in workforce and workforce planning. I know you're going to hear about that later on in the morning from Louise. We're very interested in safety and ethics. I know Lance is going to talk about that. And we're also focusing on what it would mean for the consumer, all those apps that they're going to have recommending what they should do, and also for clinicians in terms of precision healthcare, being able to give you advice on this particular patient. All those things are on our to-do list. And if your organisation that you represent is interested in this area, please let me know. We're very happy to have you join us. So to finish up, I asked that existential question, will we all be around in a short while? I love Amara's law, which says that we overestimate the impact of technology in the short run, but we underestimate it in the long run. So if you had sold your shares in the dot-com crash, you would have made a very bad decision, because within 3 to 5 years, Google and Amazon were worth a lot of money. I didn't invest, by the way. And so my advice is that we're not going to see massive change in the next 5 years in our practice, but you will within a decade. And a decade is a short period of time in the career of somebody who's just started out, and it's an eternity if you're a medical student trying to decide which profession to get involved in. We have to manage the debate about safety, and there's often a big push to be innovative at the cost of safety, and we should never let that happen. And we need to think through what are the implications for work. This will change what we do. If AI is interpreting images in bulk, then radiologists might be doing other things as well as what they do now. They might get out of those dark rooms they live in and talk to patients. That will be interesting. It's a world which will change, and the changes really are either going to be imposed on us because we have not paid attention, or we will engage and shape what happens and make sure the outcome is the best outcome for our patients, and that we have a role in that. So the question I asked you was, what is the fate of medicine in the time of AI? And I think the only thing that's clear to me is that our fate is that we are going to change. Thank you very much.
What a fantastic start to the session. We now have someone who I thought was from Queensland, but he's definitely a New Zealander. Dr. Lance Lawler is the current president of the Royal Australian New Zealand College of Radiologists and a former CEO and founding partner of Pacific Radiology. As RANZCA president, he is committed to highlighting the role of radiologists in achieving positive patient outcomes and addressing the impact of artificial intelligence on the profession. He has a particular interest in the application of AI tools in healthcare pathways, specifically just how we regulate the coming proliferation of these tools, providing the maximum benefit for patients and while shielding from the risks. Dr. Lawler will provide a broad overview of the ethical implications of artificial intelligence in healthcare, including an update on the development of the college's ethical principles for AI in medicine. Please welcome him.
I want to commend the organisers for running this session. It's often, well, it's clear why radiologists are interested in this. You've heard from Enrico, you've seen the headlines, you've seen other headlines. But it's very important that we all understand that this technology, while it's not here yet, is coming, and it will impact us all in the way that we work. And what is the role of medical colleges in helping us plot a pathway forward, particularly through the potential regulatory environments that we may find ourselves in? So I've been asked to talk about ethical artificial intelligence, to paraphrase. But this is an issue, as I said, it's very dear to radiologists' hearts. And it started in 2016 by this from Geoffrey Hinton, who is one of the leading researchers, scientists in this technology, the science of artificial intelligence. And he said, we should stop training radiologists right now. More, he said that we were like the coyote who'd fallen off the cliff but hadn't looked down yet. And that in 5 years' time, artificial intelligence would perform what we do better than what we do now. Well, that was 3 years ago he said that, so the clock's ticking. There's no doubt that it will make an impact. But what phrases like that have caused, and also the headlines that Enrico put up, is that it creates a certain amount of hype and expectation. illustrated by this so-called hype cycle here. And what that leads to, as we climb the slope of visibility and energy and enthusiasm and money associated with this, to get to the peak of inflated expectations, is that it generates a platform for the people who are developing this technology to attract money to figure out how they're going to commercialize it. Now, a fool and his money are easily parted, but you need fools to invest in these technologies because not all of the investment that's going on at the moment will yield any positive results. Of the 250 companies that were at the largest radiological conference in America, it's RSNA, it's in Chicago every year, 50,000 radiologists go. Of the 250 companies that are in this space, they all said that we're going to be the leading AI company in the world. Well, 249 have got to be wrong. So you've got to pick where you invest very carefully. What this can do is it can transpose to patients' expectations. And in medicine, we very much are wary of over-promising and under-delivering because we know our patients don't like it. We're worried about how the politicians see these things because we know how impressionable they can be. And whilst they may not make decisions very quickly, they can in the end make very bad decisions. We've already discussed, thank you Enrico, basically what artificial intelligence is, but from our perspective it's doing tasks that otherwise would have required human intelligence, particularly visual perception for radiologists, speech recognition, language translation and pattern recognition. Again, Enrico put that slide up showing that artificial intelligence contains machine learning and deep learning. Deep learning's the technology that provides multiple layers, very complex algorithms to analyze very large data sets very quickly, which is why we're seeing that at least the science of AI is progressing so quickly now. How will AI impact healthcare? Thinking about the journey that the college is on and how we came to produce the ethical guidelines that we've put up for consultation. We can see now that we're already, with the implementation of CT examinations, we're already seeing the art of physical examination as being lost, to be replaced by the radiologist, will be replaced by technology, and then after all of that, AI will take over everything. But in reality, it's just another technology that we're looking at, and radiologists, I think, are very well placed to help the evolution of this technology because the history of our profession is that every 10 years or so, something new comes along, MRI, Doppler ultrasound, shear wave ultrasound, CT PET, that is developed by the innovators, the researchers, the scientists that we have to help adapt to put into clinical practice so that our patients can get the benefit of these technologies. And that way, this is no different from what we're used to. So in the short term, like it could be now, the short term, how will AI impact healthcare? And this is a typical representation of how AI works. You've got a chest x-ray and the computer's put a nice box around something there, could be pneumonia, doesn't look normal. And that's one of the main potential near-term uses of AI in that you can go through a huge data set, a huge number of images and pick out the ones that aren't normal so that you can bring them to someone's attention to say, well, what is this? Now, the technology may be good at looking at what's a pulmonary nodule, what's consolidation, is the mediastinal lymphadenopathy, but you need to be able to still to coordinate that, and we're not there yet. Another way that this technology is being developed and promoted in the near term is comparison studies. Nothing is harder for you to take on a Friday afternoon when you open the next CT on the work list and it's a CT head, neck, chest, abdo, pelvis, follow-up lymphoma, and there are 5 other studies to compare to. So you know you've got half an hour's work in front of you that a machine could do instantly, much more accurately. So again, the technology has applications to cover deficiencies in human performance. We need to manage the transition to the partnership that we have between people and machines. And the other area where it has a near-term impact is the identification of negative studies, particularly screening programs. And this may have a big impact in developing nations, particularly looking for chest x-ray findings of TB and so on and so forth. I just wanted to mention very briefly that aside from the clear radiological benefits of this technology, the huge benefit for healthcare may be in process efficiency, so that we know that if any of you have been patients, I just have recently, you know that there's a huge unknown about what's going to happen next. I've got to coordinate this appointment with this scan and seeing this person and then followed by that person. it can be very complicated and patients can fall between the cracks. So AI has the potential for mapping all of these interactions and making them all work. Not yet. So in the medium term, very briefly, we're talking 5-10 years in the future, we're going to marry this technology with big data, huge data sets, so that we can begin to understand patterns and correlations between things that we don't observe as humans as being related, because we don't have the overview, we don't have the bandwidth to understand the huge numbers that are being talked about, that maybe will uncover some key important facts about diseases such as Alzheimer's or schizophrenia that we struggle with at the moment. So that's coming, and that will be a tremendous benefit for our patients. But, and there is a but, with all of these studies that have been shown, and the ones that Enrico showed about how this technology performs so well, better than humans do, they still have receiver operating curves, they still have sensitivities and specificities. So they're not 100%. So what happens when things go wrong? And what could possibly go wrong? Here is a study just to illustrate that was done by researchers to build an algorithm to distinguish between wolves and huskies. Why, I don't know, but that's the sort of thing that scientists do. Isn't that right, Enrico? Yes, he isn't. He's agreeing. So the program is very good, except occasionally when it diagnosed a husky for a wolf. And the researchers couldn't understand why this very basic program would misperform in such a way, till they unpicked it and they realised that, well, the algorithm, which had self-taught itself, it wasn't looking for whether it was a husky or a wolf. It was looking for, is there snow in the background? So the wolves, you wouldn't think so, but the wolves all had snow in the background, so it picked those very quickly. One husky had snow in the background, it said, you're a wolf. So unless you understand how their algorithms work, you won't be ready for when it didn't work. And it might not be as obvious as saying, well, I can see it's a husky or a wolf. If we're leading with complex medical problems, a bit harder to understand. So how is all of this regulated? A lot of it's done by the FDA, but the approval process is not as robust as you may think it is. Standards Australia has just started looking at how we regulate this technology, because before you can regulate it, you need the standards. And what should you as medical leaders be thinking about in this space? So the college's approach has been, well, we are a relatively small organisation. We don't have a lot of money. We want to make some contribution to this on a world stage. So we've decided to develop some specific ethical standards and principles for artificial intelligence, knowing that once the ethical standards are in place and everyone's had a chance to look at them, argue, evolve them, that they will become a basis potentially for rational discussions about what the standards should be for the technology. And once the standards are agreed, we can look at the appropriate regulatory environment. What are medical ethics? Well, really, it's pretty obvious, isn't it? It's just doing the right thing. Whatever you do is ethically appropriate because you're a doctor and you're a reasonable person. But medical ethics are values and reasoning applied to a situation and interaction with a patient, rather than morality as such, even though morality appears in all the definitions of medical ethics, because morality systems rely on authority, like the Bible or the Quran or a political system. And when your religious beliefs or political beliefs are in conflict with your patients, you've got to be very careful that ethics are applied at the level of the patient. Very, very briefly, there are 4 basic ethical principles that all ethical standards have to acknowledge, and ethical behaviour, which really is a promise of a standard of care to a patient. Ethical care is a balance of these 4 pillars. 1, autonomy. Clearly the patient gets to choose their best treatment. Beneficence, which is just anything that we do to a patient must have at least have a small chance of making them better. And then do no harm. So whatever you're going to do, invariably we do harm patients in the course of making them better. But in the first instance, do more harm than good. And then there's justice, which is respect for human rights. And managing the greater good, especially with scarce resources. So, based on those principles, what we have done as a college is devised 8 draft ethical principles which are up for consultation. I think it may have just closed, but we would still accept input. Which, if you like, are applied ethics, specific specifically for artificial intelligence, mainly from the perspective of radiologists, but as it turns out, they are pretty universal in the way that you would think about applying this technology into your own clinical practice. First of all, safety. It almost goes without saying that anything we do has to be done with the idea of the patient's safety in mind. So we don't want to put the patients at unreasonable risk because we see there are potential benefits. We have to balance those. And the patient also gets to decide. So if we're putting patients' images through some sort of algorithm, we have to know that that algorithm is doing the right thing. There's a bit of crossover in these two. And what did I say about the clicker? Avoidance of bias. These algorithms, by their very nature, are dependent on the data that goes in to building up their expertise, if you like. It's the wrong word. So any given data set, any given algorithm that you buy, you really should know what the data was, what the population was that supplied the data to train the algorithm. And maybe a middle-aged European population from North America isn't really representative of your clinical population that you look after somewhere in Australia. So you've got to understand that if you've got diseases that are more prevalent in one group and you apply that algorithm that's been developed based on that information onto another, you might not get the results that you think you're going to get. I think the battery's flat. Transparency and explainability. One of the big problems with AI is that you get people talk about the black box problem. So these are learning technologies that are written and then let loose on data, and they learn and evolve in such a way that the people that write them no longer know how they work. You have to be able to understand what the weaknesses are in this technology if you get a result which you weren't expecting. Is it the truth, or is it something inherently wrong within that particular patient's data with respect to the algorithm that you're using? If you don't understand how they work, you can't really be expected to navigate that minefield. Again, we're talking about huge data sets, but the data comes from individual patients, how we manage that data, not just when patients are being, or patient images are being used to train an algorithm, and there are questions about that. Everyone needs to understand what their position is and what our position as countries are with how we go about that, but also when patients' data is let loose in these computer systems, how protected is that? We need to make sure that there's no increased risk of their personal details being made available to others who otherwise shouldn't know about it. Decision making on diagnosis and treatment. You've got to use the information in the real world situation, so regardless of what the result is, you still have to apply your clinical judgment as to what may be the best to advise the patient, and again the patient gets to say what happens. This is a tricky one. So now currently when our relationship with the patient is such that when something goes wrong we feel responsible for it because we've help them navigate whatever the issue is, whatever the medical problem is, and we take responsibility for when things don't go well. Maybe we have made a mistake, maybe we haven't. But what happens when we are given by our department or hospital or state government the use of this particular program in this situation? So we didn't seek it out, we didn't really have any input in choosing it, but we've got to use it. What happens when it doesn't go, when it goes wrong? Who's responsible for that? So we need to understand where the liabilities rest so that we don't get, the doctors don't continue to get blamed for stuff beyond their control. Application of human values, again, regardless of what the software or the program comes out with, we've got to apply. The relationship that we have is a very human one. Doctor-patient relationship is very, very important. That it's not, I'm sorry, the computer says no. That's all there is to it. And finally, governance. It's quite tricky. Some of these issues are quite tricky, and we would think that at any institution, organisation at any level, that there should be a well-thought-out system of governance for how these technologies are used, particularly with respect to these draft ethical principles. So who's responsible for making decisions about its use? How is that counterbalanced? What's the role of a board? What's the role of a clinical board? And summarising all of that, we've got to make sure that the technology is fair, to everyone. Patients' privacy is protected. The technology is reliable and it's robust, and that we can trust its results. So the black box effect that we talked about, the technologies that have been licensed by the FDA very loosely are all non-learning technology. So they're technologies where the learning part has been turned off. So it performs at a certain level, and that's the way it will perform in clinical practice. So we don't find ourselves yet in the situation of having to worry specifically about it's evolved to do something else. It's diagnosing wolves, not huskies, to paraphrase. So the future of medicine, well, Enrico, AI won't replace doctors, but doctors who use AI will replace those who don't. Thank you very much.
Thank you so much. It looks like the College of Radiologists has done a lot of the AMA's work for it in terms of our future advocacy, so thank you. We may be borrowing some of your principles. Our next speaker is Professor Justin Bilby. He is Vice-Chancellor at Torrens University, where he's overseeing significant growth across Australia in the academic and research programs at a time of major reform and disruption in the higher education sector. He has a clear view that we have to innovate and rapidly adapt our current educational models as work environments are shifting to embrace globalisation, technology, artificial intelligence, machine learning and automation. As a general practitioner, he's been widely recognised as a leader in primary care and general practice reform in Australia. Professor Bilby will provide a specific perspective on AI and its potential impact on general practice. Welcome.
Thank you very much, and it's a pleasure to be here, and thank you, Omar. So what I want to do today, if I can just get this to go forward, is pick up four quick areas. I'd quickly just pick up two technological principles. I actually, as a GP and a researcher who've been involved with data and information for almost 25 years, had to find some examples to make this come to life for me. So I'm going to quote two small examples, one in Australia and one in the US. We'll talk a bit about what I think the lessons for general practice are, and then some of the possible future conversations, but I've been well versed by the two previous speakers. So GP working in Adelaide, and basically a GP who's been working with data around research, information technology, quality assurance for 25 years, and have been looking for the use of data in an efficient, personalised manner inside our consultations. We are on the cusp of a digital revolution with multiple evolving technologies, and we have to be part of this. The amount of data is doubling every 8 months. The computer power is doubling every 18 months. And I go back to what I feel very strongly, the GP is at the centre of the healthcare system in Australia, with 85% of the people coming to us each year. The potential for using AI tools in clinical practice with appropriate guidelines is extraordinary. Our data is powerful, it's valued, it's shared by providers across the world, as all of you know in the room. But what I'm trying to think through today is how we make that come to life in a personalised consultation focus. Machine learning definitions we've been through, artificial intelligence, which I see is the face of machine learning. It's the way I can think about this, and the diagrams of that little Enrico's 3 circles actually gives me a sense of the deep learning, the techniques that are part of that technical skill set. We have to bring the face to that. We have to own that face as it moves forward. There's a really important Moore's law around IT. The issue of computer power is doubling every 18 months. Well known, well proven. It is coming, and the potential is increasing that quickly. This is the graph I just want to hold for 2 minutes. This is what's called Martek's law from an IT perspective. And if you look at the graph, the technology is changing exponentially on the left of the top line. But organisations travel much more slowly, logarithmically, in a flattened manner. And the key point for me is that red point. This is probably the key point of my whole talk. We have to actually develop a balanced partnership between AI technicians, or people who do this for a living, and clinicians, including us as we as GPs, which is my focus of my talk, so that what we look for quickly and effectively is how it benefits our patients and our communities and our healthcare. And I think that's the bit that's not, I don't see a lot of evidence that that's their building, but we're getting there, I think, as we move forward. This is actually a really nice piece of work, and this is all down to Chris Pearce's team in Victoria. I want to spend a little time. It's a very busy slide, which hasn't landed easily on the deck. This is a piece of work that's been done in Victoria. It's called Polar Diversion, which has just been published in the Medical Journal. Chris Pearce and the team took data from 50 practices across Victoria and New South Wales. They took nearly 17,000 GP visits, looked at nearly 8,000 patients, and tried to predict, using a set of AI tools, those patients who would present to the ED department. So this is real live Australian AI work in general practice, which is the bit I was trying to tease out here a bit. And basically with these patients, they found that within 30 days, the positive predictive value of the tool they developed when they linked the GP data sets with the ED data sets was about 74%, with a specificity of 68%. Importantly, if you look at the paper, this falls off after 30 days. The data gets poorer and poorer. And the important thing that Enrico's picked up already, we're still not there. This is 25% that's not accurate. However, non-ED attendance was nearly 82% with a positive predictive value and sensitivity and recall of 96%. What the Polar team found, what Chris Pearce's team, and I acknowledge that very much and I've had a number of conversations with him, it was better performance than other tools, particularly already in the literature, particularly for 0 to 30 days. It's better because it's based on the GP system data alone with the ability to create a real-time consultation warning. The DST tool, the AI tool, was run in the general practices for 6 months in the second half of 2018 and managed by the primary healthcare networks, which is something to think through as we evolve and develop the work in this space. It would provide an at-risk live profile on the desktop of those as the patient came to see you as a GP, and would give you a risk from very low to medium to high to very high. So that would be sitting on your desktop, and the moment they're currently developing it further as we go into the future, on the desktop as you're talking to the patient in front of you. Now, if you step back a bit, basically the GPs were accepting of the model. The recommendations of who would probably present at ED made sense to the GPs. There was absolutely no trust with the predictive ability with children, was what Chris said. But the important thing, the DST tool doesn't support, it provides support in the room for you. It doesn't replace our decision making. And a bit of the Terminator discussions, the AI, the robots taking our lives, I actually think what will happen, our clinical practice will evolve and change, and I'll get to that at the end. I think where we'll be going is a triangle of the computer, the patient and the doctor, working in a partnership that I think in the next 10 to 15 years will evolve in a really quite exciting manner. I no doubt someone in the room will ask me about the value of the data. It's clearly going to be a question, so I'll preempt that question before you ask me. Good clinical data is the key, and what Chris did with his data and his team, they coded all the data before they ran the tool. So it's important here that the data in that equals the data out, the classic data junkie GP conversation that everyone has in life. But the important thing is the data, the bias that we've talked about already needs to be covered and clarified. Goes back to the second key point I want. To make GP, and we have medical records, we're well computerised, and I've been around long enough to know to be part of the initial startup of the computerisation for general practice. The better the data, we have to see the value of it. The more the data, we use the data, the more value it will be, the more we will value what these tools can deliver. So from a clinical perspective, that's one of the second points I want to pick up. If we're going to be part of this revolution as clinicians, we have to work our way through making sure the data is accurate for what we want out of it. Second study is we're just starting some new work in Adelaide looking at AI tools with some aged care databases, looking at whether we can predict frailty and falls with patients within an aged care setting. We're just doing some pilot work in Adelaide and we'll extend that nationally. This is a piece of work that one of my researchers is doing with some women in in the US, some actually Puma Indians, looking at a small data set where she used AI tools to look at predictive ability for diabetes. It's about 768 women. The reason I'm showing this example is I wanted to understand AI for me clinically, I have to see it come to life. I have to see how it can actually work within the constraints of what we do as clinicians. Took the data set, looked at 768 women, and designed an AI system to predict diabetes. I showed this I normally wouldn't do this, but this is the classic primary care data set. Blood sugar concentration, diastolic blood pressure, BMI, age, pregnancy outcomes, our data set, the data we deal with all day, every day as clinicians. What they designed in the red box in the middle is an AI predictive tool. They fed in the variables on the left, the inputs, plasma glucose, insulin, BMI, blood pressure, age. And then the outputs, what the tool was, looked at whether you were diabetes prone, healthy, or needed future tests. The bit that's interesting for me is the system, the word trained is a word I want to pick up. The issue of the trained with your own data set, with the 658 patients, to show whether, and they had a clear diagnosis on whether they were diabetes. So the algorithm was trained and tested with the people with diabetes, and then tested again in a performance data set with patients that they did not know the outcome. This is a very busy slide, but the two key points for me in the box in the middle, we looked at 55 patients who were diabetic, and 80% were predicted on the tool they used that they developed for the previous data set as I just described. The 55 non-diabetic patients, the tool predicted that 40% needed further follow-up. Importantly, there were no false negatives and no false positives in that data set. While it's an American data set and it's very specialised, what I'm trying to illustrate the importance of the learning that goes with the tools we use, and involving ourselves with that learning process, making sure we feed in the right attributes with what we want as clinicians as we move forward, is something that I think is where we're moving to a different cusp. Laurie's talked about the ethical principles, which I think are incredibly important, but I think where we need to step forward as an organisation, as a group of clinicians, is to start asking how we want to use the data in a clinical sense and guide that discussion to make sure we end up with material that helps our clinical care. And I think it's important to be here now involved as we move forward. So the challenges for me, 20 years' time, computers, there'll be no keyboards, voice activation with active AI support. Already two of those previous speakers, the big jump in AI will be augmenting human skills, but it'll be 10 or 20 years away. But I feel very strongly, having gone through a number of major changes in general practice, we actually have to start now. The use of computer data sets, the Digital Health Agency that just landed is 15 years past where we're trying to go. I was involved with the National Health and Hospital Reform Commission 10 years ago. When we set that up, things are just beginning to fall into place, such as patient linkage and patient alignment with practices. So I think it's about starting now to be part of that conversation. There will be turbulence, there's no doubt, and it will be difficult. There will be difficult conversations as we move forward using this data in our clinical practice. The quality and the benefit of the data has to be important to us as clinicians. And both those examples I showed you, both the work that Paula did and the work that one of my staff did around the prediction of diabetes, is beginning to clarify for me that we're trying to build a story that actually gives us a value for the clinicians. The two final points really are, I think, one of the other 2 points I want to pick up, and this has been well documented. The phrase unleashing AI on a largely unsuspecting public. As clinicians, I think we have a role to play in this discussion. I think we have a role to take the community with us as we move forward. And I think it's a really important point as people start using AI tools in clinical practice, as you explained. And I had this conversation with another at a recent meeting around AI and company directors training. And the person who is the AI expert said, basically, you've got to take the patients with you to understand the tools you're using in front of you and the value it is. So as much as we sit and use clinical records when we type in our notes or prescribe, this is a different set of conversations about that personalised touch as we go forward. And I'm really strongly of the view that we actually need to define digital competencies as part of all the I put GP training program because that's my focus. My view is everyone training and graduating today should leave both medical school and undergraduate or postgraduate training with digital competencies. So it's in our AI and GP for me is in our hands. We need a balanced partnership, as I've said, between AI technicians and clinicians. We will have to grapple with the issues, as Laurie said, around privacy, data integrity. Interestingly, intellectual property, who owns the data and the practices, how's it to be used, and regulatory issues, which I think will need to be interwoven into standards as we move forward. We have to pilot, map, discuss, and Enrico's discussion from a national framework is incredibly important because every single person in AA is on that slide. And Enrico, well done for you for getting them together. But we need to pilot, trial, but we need to make sure that we as clinicians have some significant say in that. And this is a really lovely quote out of the Medical Journal of Australia paper. The clinical interaction in the future will acknowledge the strengths of each party, patient, clinician and computer. It's a really interesting quote if you think about it. Just step back a bit and think of the triangle in your consulting room or in a radiology room or your pathology room or your IC room. It's really quite an interesting concept to think through. So to finish, clinical decision making, we all know, is complex and easily accessed patient-specific data will help the final choices. the slide that Enrico showed about the mapping of best care versus AI care, as we go forward in the next 5 to 10 years, the emerging AI technologies are pushing us to the real possibilities of a personalised diagnosis and the management on the tap of a keyboard. And for someone who's worked with information with my patients and our patients as clinicians for nearly 25 years, getting to that personalised touch in the next 10 to 15 years really is very appealing, as long as we guide and shape the agenda as we go forward. Thank you all very much.
Thank you so much, Justin. I think we're starting to get a picture of what AI actually looks like in our consulting rooms. Our last speaker is Dr. Louise Schaper. Louise is CEO of the Health Informatics Society of Australia, where she brings together world-class clinicians, researchers, innovators and organisations from across the biomedical, health and technology spectrum who are committed to the improvement of health outcomes enabled through innovative use of technology and information. With a background as an occupational therapist, Dr. Schaper has a PhD in technology acceptance among health professionals and is a passionate advocate for the transformation of healthcare. Dr. Schaper will address the implications of artificial intelligence on the future medical workforce and how the medical profession can best prepare itself to ensure AI's successful integration into Australia's healthcare system. Welcome, Louise.
Thank you. So camera guy, I'm going to stand out here, so I'm short. You won't see me if I stand behind the podium, and I wore my big girl shoes today too. Good morning, everyone. How are you going? You enjoying the conference so far? Yes, excellent. I wish I could stick around. You've got some really good stuff on the program today. So I'm going to be talking about the impacts on workforce and a lot of it around the business models of healthcare. Because as we know, the reason this session is even here today is because health is on the cusp of a technological revolution. What does that mean for you? How do you feel about it? Some of you are going to be this guy. You're going to be like, yeah, okay, I'm pretty excited about this. I think this is okay. And some of you, not so. You're going to be this guy here and you're freaking out. But you don't want you're cool, but inside you're freaking out because you're like, well, hang on a minute, what does this mean? Is this really going to happen? And some of you will have colleagues that are like that as well. And others will be the third guy on the slide who are like, meh, doesn't really matter. Going to be retiring soon. These experts here are saying, look, 10 years at the most, don't worry, the Terminator's not coming for us yet. By the time all that happens, I'm going to be out of here and I'm going to be, cruising the Whitsundays on my boat or whatever it might be you have planned for your retirement years. Anyway, but you can keep that to yourself, but you'll know which one of these emoticons you guys are. And when we talk about the future of healthcare, artificial intelligence is one technology which is absolutely going to be transformational. But what is critical is how we use it. How we use this technology as the responsible clinicians that you are to get information into the hands of the people who need it, which is yourselves, your colleagues, and your patients. One of the reasons we're not there yet isn't just that technology hasn't got to the point that we need it to. This is the main reason why not. Because every single healthcare institution will need to change their business model. That's including you guys, including the podiatrists down the road, public hospitals, GP practices. We will need to look at the way that we change healthcare, and that is something that I certainly wouldn't want to be the politician getting up and saying, hey, why don't we change the way that we do things in healthcare? That's the challenge, and it's a very real one, and that will actually temper the growth of how we use technology as well. But regardless, whether we like it or not, healthcare is changing. And healthcare that was once delivered in physical institutions, and some of you would work in those institutions, the majority of you are working in those organisations where we expect people to come to us, that is going to change. And we're already seeing that change, slowly, yes, but there are changes afoot, where we're actually going to see more and more therapies and medical practice being delivered outside of healthcare institutions, in people's own homes, in the community, and virtually, and using technologies to enable us to practice healthcare to even more people. So how do we prepare ourselves? How do we prepare our workforces? How do we prepare our businesses for this stuff? So yes, we know it's not happening tomorrow, but it's really good to be having these conversations now. It's important that we are architects of our own destiny. sitting back and thinking, and being that third emoticon guy saying, doesn't really matter. You know, I'm sure it'll be a long, long way in the future. No, that is not the right thing to do. The right thing to do, as you guys are here at the AMA, is actually thinking, well, we need to be thinking about this now, and following in the College of Radiology's footsteps, who are doing substantial work in this space. So when we think about things like artificial intelligence, what would that mean practically? Well, these are the types of things it could mean practically. That within 5 years, the majority of clinically valuable data won't be generated by you in your clinical care settings. It'll be generated outside of those walls. What does that mean for how you practice medicine? What does that mean for your patients? What does that mean for how all this healthcare business stuff works? Consumers, and you're seeing more of it, gone are the days of Dr. Google. I mean, that's so 1990s almost in a concept. You know, we've got, and you guys will have your stories and you'll know, and I'm sure you share them over drinks at the conference dinner, of consumers who are really expecting that you treat them differently than previous generations have been treated. The information they expect from you and the nature of the relationship will continue to change. Patients are actually going to continue to request to have access to their own data. This is happening all around us, and you guys know it. I'm sure if I said, hands up anybody who doesn't have a smartphone with them right now, you know, there'd be nobody that would be brave enough to put their hand up. And if you were, it's probably because you're like ran out of your hotel room going, shit, it's on, I've got to go. And you left your phone accidentally, and you're sitting there freaking out going, oh, I don't know what's happening in the world. I don't have my phone on me. You know, like, so this disintermediation where we're taking out the middleman and we're expecting services to deliver at the point of time we want them, that is happening to healthcare as well. No time to go into this today, but if you're interested in these things, have a look at the fourth industrial revolution, where we're really talking about this intersection of the digital world, us, the biological world as humans, and the physical spaces that we occupy. This is transformational change. We're talking about artificial intelligence type technologies embedded in all sorts of devices, fridges, toothbrushes, all sorts of things, socks that you can wear. Any Princess Bride fans in the audience? There's always Princess Bride fans. I'm like, and if you're thinking, what is Princess Bride? Just, you know, Google it, look it up, watch it. There's a character in Princess Bride who likes to say, you keep using that word and I don't think it means what you think it means. And it's people using words out of the context that they're intended to be. Well, that's something that digital health is vastly different than when we talk about health IT or e-health. When we talk about digital health, we're not talking about the application of technology into healthcare and how do we use it. And this is the really key important point with artificial intelligence and related technologies. We're actually now talking about how does healthcare fit into the digital world. It's a different way of conceptualising these things and what it means. And if you think of it that way, you can really see that this is really significant change. There's an organisation started in the United States, what's actually sort of a movement called Open Notes, and I know a lot of you have computers in front of you. If you go to their website, opennotes.org, you will see that there is a ticker on their website of how many people have full access, not a summary, full access to their clinicians, their GPs' patient notes. When I last took this slide, it was 30 million. I think it's now over 40 million, if you're looking at the slide. Full access. Yep, the lady's nodding there. So it's over 40 million people now. This is where I like to say every man and his dog likes to get into digital health. So there you go, I've said it now. Okay, so Alphabet, company you may not have heard of, but you would have heard of its subsidiaries. This is Google. So where they restructured Google a few years ago when it became Alphabet as the parent company and Google as one of the subsidiary companies. These guys are the second most valuable company in the world. We're talking about over $800 billion value. And when you look at if you look at the research, the news articles around creating Alphabet and what was that all about, you will see healthcare and medicine attached to every single one of those news articles, every single one. Google are making a significant play into healthcare. What would that mean? This came out just in February this year. Oh, Google might be building an electronic health record. Well, I don't think they are. But I think what they're probably doing is using the artificial intelligence companies that they now acquired to analyse records and present them in a standardised data format for use by patients, for use by clinicians. I mean, they haven't released this yet. But, you know, you mentioned before, Lance, 250 companies talking about artificial intelligence and we're the artificial intelligence company. Well, I can tell you, when you've got a company worth this much money, they acquire you if they think your technology is good. They've already acquired lots, like, I don't know, 30-something artificial intelligence companies and technologies now are owned by Google or by Alphabet. And so every time you do a Google, every time anyone around the world Googles something, you're not just getting excellent search results because of the technology, they're learning from you. You are teaching its artificial intelligence laboratories about how we think and the types of information that we're after. So it's often said that a child that's born today won't ever need to learn how to drive a car. As a girl who grew up in the country, that car symbolises your independence. That really is a strange concept for me, I must say. But the idea of not needing to drive a car because of self-driving technologies, well, we could apply that same philosophy to potentially the child born today won't necessarily see a GP as their first point of call to get a diagnosis for what's wrong with them. That could all happen in their own homes utilising technology. Now, whether we think that is good or not, regardless, technology will push us in those directions. It's really important for us as the medical profession and looking at the ethical standards of all these things to be involved, to have a voice, to educate ourselves around these things, to make sure that as the technology is going into the hands of people, and we won't be able to do anything about it when you've got large companies like Google and Apple playing in this space, to make sure it's done well and to make sure that there is still a critical role for us as clinicians. I've got a couple of slides here of Enrico Cuera, and I left them in even though I knew he was talking today because this is the stuff you should read. His stuff is brilliant. So this came out last year. Could artificial intelligence make doctors obsolete? I will let you know. You can ask Enrico in the panel what you think his answer is to that. The fabulous Warner Slack, a doctor from I'm glad you like his quote, a doctor from Boston. He died last year, and he's a fabulous doctor and a health informatician. And he said quite some time ago, and it was a theme throughout his career, he was one of the earlier artificial intelligence researchers in this space, did say that any doctor who can be replaced by a computer deserves to be. And yeah, I'll leave that. Another great thing Enrico wrote, you should read that. This is a book that just came out, Deep Medicine by Eric Topol. Eric is an American doctor. And I haven't read it, I've listened to it. So driving around to the country recently, and I listened to this audio book. And his central tenet is that artificial intelligence, yes, is coming. And what his point is that by enabling, and I really liked the previous speaker's comments on this as well, by us as clinicians actually utilising the technology and enabling us to actually get back to what we love, which is treating patients, which is helping people, instead of being just, focused on a factory of getting people through the door and not being able to take the time. Artificial intelligence will enable you to do that, and there is lots of examples that Eric gives in his book. Radiology and pathology is changing. Now, at the moment, me as a patient, do I ever see the radiologist? Do I ever see the pathologist? No, I certainly never have. Now, if I'm really sick, and depending on, maybe I will have an opportunity one day to actually have a face-to-face, but that is rare. The majority of us as patients, we see our GPs, and it's only if we're really sick that we end up seeing specialists. But I've had blood tests done recently myself, and I've also had a MRI done recently. I didn't speak to the radiologist. I did not speak to the pathologist. I spoke to my GP. But one of the things that these professions, pathology and radiology, could be looking at is, because if technology is going to enable them to do their jobs, radiologists won't need to be the diagnosticians of the future. That'll be done by technology. What's the role for them to play? And obviously the College of Radiology is doing a lot of work on this space. But potentially, maybe a business model might be for me, the patient, to actually have a face-to-face with the radiologist, to actually have a face-to-face with a pathologist. I know, like, I'm not saying this is a good thing or not. But these are things that you're going to have to consider. There will be changes afoot. And if you're thinking, no, don't want to know, that business models can change that you actually don't think are the right thing in the consumer's perspective or in your clinicians. But these are things to consider. One thing I'd leave you with is one company that's doing things and you recognise this logo? Not everyone does. It's Amazon. Okay, so this is Amazon. Why is Amazon doing anything in healthcare? So it's Basically, last year it was announced that Amazon has done a deal with Berkshire Hathaway, that's Warren Buffett's company, and JP Morgan Chase, the big bank. Now, together those guys employ a lot of people. They employ over 1 million people. And they've decided to join together to form a healthcare organisation to deliver healthcare to their employees. And again, if you're not in the space, you could just think, oh, okay, well, whatever, they're probably just contracting it out. I don't think so. I think what they're doing is actually, it'll save them money, the way the American healthcare system doesn't work, let's say. So it will save them money and they'll be able to provide care. But what they will be able to do is actually work out how to provide care differently, what the business models could look like. Where do you get your clinicians from? Who do they work for? You'll get these slides later, I'm sure, so you can have a look at that. But these things are actually not just about helping their employees. It could be a sandpit for them to do research to take this model to the world. Recently in the White House, this was from Twitter, and these companies got together and they were at the White House in America saying, okay, we're going to have to fix this interoperability problem of healthcare. So the idea of data in healthcare all sitting in silos, that it's really difficult to move it around. So these companies saying, yeah, we're going to fix that problem. Great. Now, who were those companies that showed up at the White House and signed this pledge? Amazon, Google, IBM, Microsoft, Oracle, Salesforce. None of those companies would be recognised to most Australians as being healthcare companies. In the industry I'm in, most of those companies wouldn't even be recognised, and certainly not a year or two ago, as being health IT companies. These are not the major players, and these guys are going to disrupt. And this is you've probably seen this on your LinkedIn or your Twitter feed. So Netflix didn't kill Blockbuster, ridiculous late fees did. Uber didn't kill the taxi business, limited access and fare control did, and there's a list of them. Well, I'm wondering how long, if we aren't paying attention to these things, how long before the next thing on that slide is that Amazon or artificial intelligence didn't kill the healthcare industry. But having a healthcare system that doesn't remember me, something that our next keynote speaker, Tim Kelsey, likes to say, and I agree with him completely, a healthcare system that doesn't remember me, that doesn't actually treat me as I want to be treated. And if there are other companies, big players with massive money, bypassing regulation, bypassing government, and coming directly to me as a consumer, and it looks good and it sounds good, why would I not? And this is one which I won't talk to, I just thought I'd leave it there for some humour at the end. All right, thanks for your time, everybody.
I think the suggestion that radiologists should see patients was just a step too far, though. That is, after all, why they chose to be radiologists. We won't go into why I chose to be an orthopaedic surgeon. Now, now's your chance to have your say. We have 13 minutes and 17 seconds for questions from the floor, so please move to the microphones. I might actually get things started just asking a simple question of whichever member of the panel would like to answer it. Around the data, we've heard a couple of you mention the importance of data, but it is a problem. It is siloed, it's poor quality, certainly in the hospital sector, and our fragmented system fails. And then you've got privacy legislation, which says we're not allowed to do this or that without explicitly telling the patient. So how are we going to improve the data?
So I'll go with that one. I think it's the wrong question. I think the data it's actually asking, how do we make the data valuable to us? It's not about improvement, it's actually proving that if you gather good information, your clinical care improves. So you change the question, what I think needs to happen. The data that I gather in general practice, I've coded for years, some people don't code, but I can look at all my people with diabetes and download that information because I want to know what my clinical care is. So the question needs to be reversed, that we have to see the value of the data as clinicians. If we do the extra hard yards, it starts to improve. So it's a process we have to evolve, as I see it clearly.
Did you want me to comment on that as well? I was just going to say that from a workforce perspective, we have to actually realise that when we are training clinicians in universities and then on the job training as well, so we don't want to just think, oh, future generations will fix everything, is actually that this stuff is important to know. So what we find is that for a lot of clinicians, especially hospital-based, the hospital buys an electronic medical record type system, And unless you're in the know, the majority of clinicians just get told, hey, we've bought this system, show up on Friday to a training course, and you get taught how to learn how to use the EMR. That is not, that's better than nothing, but that's not the right way to go about it. If we want to look at the issues that are important, and the data is critical to this, to get it right, is to actually make sure that clinicians actually are trained in informatics and actually understand, have a base level of understanding around why these issues are important, what it impacts to them, what happens to that data that they collect, why it's critical that it's clean and reliable, because it's not just your data anymore, it's actually our data collectively.
Can I just add one thing, just for 30 seconds? So we've had direct experience with homogenising data. So in our own practice, you think it would be easy. So we bought a business analytics program at great expense to build a data warehouse, which we had to go to a third party to buy and then clean up the data. That's our own data, but we had issues with interacting with the business analytics platform because the data wasn't in the right format. So I guess what I'm trying to say is this is a very expensive exercise. It can be done, you can clean up data, but someone's got to pay for it.
Okay, we'll go to microphone 2. I think that's PK, so I haven't got my glasses on.
Thanks, Omar. I'm a physician from Western Australia, and thank you to the panel for a very thought-provoking presentation. My question is about liability. It's not about driverless cars where, if it runs over someone, I get it. You have no-fault insurance, and it probably solves the issue. But every year, countless health professionals, including myself, we do mandatory training in, say, like defibrillators. The modern defibrillator actually tells you what to do. It gives you instructions. So if one of my colleagues or a health professional was at a resus and the machine tells it to do something and the algorithm was wrong for whatever reason, because we didn't check the leads or whatever, how do we resolve that? It's happening now every day in most hospitals.
Look, that's one of the key platforms of the so-called ethical approach to using this technology, and that currently now we're in the gun. We feel responsible for the machines that we operate or we set the parameters of. But the question is broader than that, is that what happens when we are told to use things without being given the resources to adequately oversee and manage them, particularly in radiology as I see it. So that's an issue that has to be resolved, and that's not something we can decide on today, but it's part of a much broader discussion. I've got my view, and I think the doctor is primarily responsible, but then if that's the case, I want to be in a position of being able to have enough time and resources to do my job properly. That might not be the...
I'll go to Chris Moy now.
Thank you. I'm Chris Moore, I'm a GP, but I've got two roles. I'm the chair of the Ethics and Medical Legal Committee, but I've also been involved with the My Health Record for a long time, which has been an interesting journey because at various stages I've been, people have viewed me as sort of selling out for the profession or we're letting down the profession, and it's been an interesting journey. But you see, I've always looked at it through the prism of one thing, which is actually the humanity, or bringing humanity back. And I'll explain why, because I think we're in this terrible stage at the moment. We've got data overload. And data overload is a situation where I have a patient who comes into me with a carer who doesn't speak, and the patient doesn't speak English, and I've got a 15-minute appointment, and I spent all the time digging up this data and by the end of the 15 minutes, there ain't a lot of humanity left in the actual consultation to spend on the consultation. And so for me, the journey was always actually that if I get the data quicker, I can spend more time actually applying humanity to this, because I think that's what patients actually want of us. That's the thing we bring of greatest value to our consultations and our interactions with our patients. And I can see where AI can also take this further. But the two bits are, we have to apply ethical principles, which I think have been indicated. But more importantly, and it's been my main thing with involvement in My Health Record, we have to actually be involved at the very start of the workflow. We have to actually make it work for us and understand where AI has to fit and where the data has to fit. Because if we don't, then we lose control of it, and it actually becomes a problem, not a benefit, and it actually decreases the humanity of our interactions with our patients. So I'll leave that at that.
So Chris, that's music to my ears really. The issue for me is around the piloting model is not so much around the data and the AI and the personalised stuff, it's actually working at what it does in the room and how it changes the relationship. And my quote around the triangle of the computer, the patient and the clinician, we actually have to think about this seriously, and I agree very much about the training side of it. We have to train our students in all professions, and in the training programs to think about what this is going to do to how you interact with that patient. The potential is extraordinary, but you have to think through how you explain and work that through.
Thank you very much. I'll go to microphone 2.
Dave Chapman from Darwin. I'm a psychiatrist. That was a very interesting set of talks. From my point of view, all of medicine is pattern matching. So I have every expectation that computers will aid and replace much of that for me. The problem isn't the pattern matching, the problem's capturing the data in the first place. And so I'm curious to know what the panel thinks about that part of the process. Doctors are very good at capturing input. It's then getting it from there into the machine to do the pattern matching.
So one of the things we haven't spoken about today is other uses of AI, and some of those companies you just heard Louise mention are also involved in projects around something called digital scribes. So these are technologies which would capture the data for you, even the data that's involved in the spoken conversations you have with your patient. So the idea will be that if you roll forward 20 years' time, the whole consultation space, if you're thinking about primary care, will be digitised. Every tool that you use will be feeding data straight into the record. Patients will have already completed before they come and see you, with it's virtual real questionnaires, which also extract lots of data that you don't have to ask. And that conversation, imagine you've got Siri today, you'll have your scribe sitting on the desk or hanging around virtually and probably auto-populating most of the record for you. So if we get that right, some of that burden which modern-day electronic records have added to healthcare, partly because we weren't involved in the design of those systems and we abdicated as a profession engagement with the records, will be remedied, I think. But my worry is that so much cool technology is coming, but we will just simply be the acceptors of it rather than shaping the workflow. And so we could have a world in which we have more time for our patients, but I can equally imagine a world in which it's just worse. So if it's not going to be worse, we have to shape it.
No, I'm sorry to everyone at the microphones. We've got 1 minute left, so I'm going to take one last question from microphone 1, and I apologise for everyone else. You might need to grab the speakers in some other format, but Ken Singh.
Thanks, Omar. So I'm Ken Singh Lim. I'm a general practitioner from Western Sydney. So my comment actually follows on or segues from the last 2 speakers, and that is that our observations about what this use of data means for our workflow and what we do. So I've got a general practice in Western Sydney. We run a predictive risk tool across our population of about 4,000 patients, roughly every 3 months. We work out what the hospital risk, or rather risk of admission is per patient, ranging from 24% down to 0% for some. This is not actually improving our workflow. This means we've now got a lot more work to do than we had before. So we've got this question which comes up, which is, do computers replace humans, or what does it do instead? So if we follow that, what I would be seeing is that this is actually increasing the amount of work we do, which, and we've been talking about this very much along the lines of what happens in the consultation room. But I'm going to ask the panel this part. Do we need to broaden that discussion and not talk about what happens between the doctor and the patient in the consultation room, but what happens in that whole practice system? Because, we're not going to be able to provide all the time that's needed with the workforce we've got. So is part of the training also about that systems building? So it's systems and technology and that nexus between the two.
Look, I think that's a really perceptive question. I think Enrico gave you half the answer when he talked about in 10 or 15 years' time, much of the work pre the consultation room, which I concentrated on, will have been gathered already because the systems will have been established in the practices to respond. So I think that's the bit it's not so much the workflow in the room, it's the workflow of the whole business that needs to be reshaped. And that's something that I think we do need to be involved with, because I do not want to just be an acceptor, as Enrico talks about.
Absolutely, and I think we're all touching on that theme. It's incredibly important that you guys need to be architects of your own destiny. And it's sort of like a 1.0 stage that we're in. The way that medicine is practiced over the next 50 years will look radically different. But it's not just, so at the moment you've got a lot of clunky systems that you have to use and things that just make your life more difficult. There's no beautiful dashboard for the patient data that you want to see that'll actually make things useful for you and for the patient. Those things will change in time. It's a bit frustrating now because we're not there yet.
Okay, I think you'll all agree.
Sorry, 1 second, I know you're running out of time, but we haven't talked about the cost of all of this, and if we had a solution now that come off the shelf and we could plug it in and it takes over, that's fine. There will be a transition phase, which means you're paying twice for essentially the same service. So the people who develop this technology are not going to let us use it for free, so therefore someone's got to pay for it. Who's going to pay for it and how? It's going to cost a fortune, so that hasn't been discussed either. Sorry.
On that positive note,
somber
Lance.
point. Yeah, thank you for rounding it out such a positive way. Well, I think our desired outcome of increasing the delegates and the AMA's literacy around artificial intelligence and the future of healthcare has certainly been achieved, and I've got a few thank yous. Firstly to Kate Stockhausen for organising this session and finding this such a fantastic panel for us, so thank you very much, Kate. To the panel themselves, this has been a really interesting discussion, and you've given us an awful lot to think about and a lot to work on into the future, and I think we will be in touch as we develop our policy as a medical association and as a profession going forward. And before we finish, there's one last thing. While I've just got the microphone and Bev hasn't attacked me with a knife yet, there is somebody who's this is their last national conference after 30 or 31 in a row. He's sitting there pretending he's not listening. But Paul Boyatzis, the CEO of AMAWA, is retiring. And while I've got the microphone, I'm not going to say much about Paul. We've got plenty of other opportunities for that, but just an opportunity, I think, for the National Conference to recognise his contribution over 30 years and to say thank you. So thanks again to our panel, and we'll finish there.
Thank you. I'll text them to you. Yeah. It's the best angle I could.
Technology, thank you very much.
All right. Thank you very much, Omar, and thank you also to the panel. That was a terrific session, and it's no accident that that session was positioned next to the next address. How are we going? Is it the artificial intelligence which has swept through the room that's... Damn. Okay. How do we get rid of that light, cameraman? I need a human intelligence to come and sort the light out. Ah, okay. All right, well, look, it's my pleasure to introduce our next speaker, Tim Kelsey, who is CEO of the Australian Digital Health Agency, and the Australian Digital Health Agency is one of the major sponsors of this national conference. So Tim is the Chief Executive of the Australian Digital Health Agency. Before that, he was the first National Director for Patients and Information in the NHS in England. He has a very interesting backstory. He's a leading advocate of a popular knowledge revolution in our public services, and in 2000 was co-founder of Dr. Foster, a company which pioneered publication of patient outcomes in healthcare. Before that, he was a national newspaper journalist, television reporter, You work for The Independent, The Sunday Times, Channel 4, BBC, also Telstra and McKinsey. So that's quite a set of skills that you've brought to the Australian Digital Health Agency. Tim, we look forward to your address. Thank you.
Well, thank you very much. Indeed. If I could just start by acknowledging the traditional owners of the land on which we meet and pay my respects to their elders, past and present. And if I could also just thank you, the AMA, for over the last 3 years since I've been Chief Exec at the Australian Digital Health Agency, really supporting and challenging Australia, as we just heard now, to think differently about how it can harness the power of the modern information revolution to the best advantage of you, the clinical community, your patients, and the communities you serve. And thanks particularly in the light of events of the last 12 months or so to Tony, your president, to Chris Moy, to many other members of the AMA team for doing such great work in helping support the development of My Health Record and more broadly the National Digital Health Strategy. So just to pause and acknowledge the tremendous work that's already been happening. I was actually had the privilege of being at the Leadership in Training dinner last night. I'm sure many others were there too. And what an extraordinary, inspirational moment it was just to sit and talk to some younger doctors about what they feel about the opportunities and challenges of technology and practice. How do we get to embrace the potential of artificial intelligence when so many of the basics just are absent? And we can hear in the background of modern Australian healthcare the hum and whir of the fax machine, and persistently so. So kind of how do we get the basics in place? And one of the things that happened last night was all those attending were given a copy of Atul Gawande's book, Complications. Now, interestingly, Louise mentioned the Amazon Berkshire Hathaway proposal or plan business, and of course that is now managed by Atul as chief executive. And anyway, I was just flicking through the pages of Complications last night, and I just came across this quote from one of the great inspirations in digital health, and indeed in modern medicine, I think. And it was this: "The thing that startles me is how fundamentally human an endeavour medicine really is." And that word human, Chris mentioned it earlier, is what I really want to communicate today, that we can talk about digital, about AI, but fundamentally, the purpose of digital health, the purpose of technology is to support you in that human encounter and to complement and enhance the humanity of medicine itself. Clinical leaders in this room and beyond are putting digital to work in the community they serve, and it's hard, it's not easy, but it really is beginning to happen. And I just wanted to share with you a couple of those examples. I was in the Southern Highlands 2 or 3 weeks ago, just after Easter, met a pharmacist in Moss Vale who, for the first time, believe it or not, in such a fantastic health system as Australia has, was actually able to see the discharge summary of his patient through the vehicle of the My Health Record. So Maundy Thursday, before Easter, elderly gentleman discharged from local hospital. Saturday, pharmacist opens up his facility to provide services to his regular customers. In comes the daughter of the elderly gentleman with his Webster pack with a single message, which is, Dad was told when he was discharged he needed to stop taking the little red pill. That was all he could remember. There was no discharge summary, and so the pharmacist sat down and was able to look up what the little red pill was, but he just thought for a minute he'd actually have a little look at the My Health Record, post-opt-out, and there it was. The gentleman had a My Health Record, and in it was the discharge summary. And the importance of that was that not only had the doctors in the hospital told the elderly gentleman on discharge not to take the little red pill. In fact, in the discharge summary, he was able to identify 6 further pills that the gentleman had been told not to take. And in this pharmacist's view, professional view, that gentleman would have come to harm if he hadn't been able to see the discharge summary in the way I've just described. And that, unfortunately, is not currently still the normal currency of information sharing in Australia. But My Health Record there, at least, is making a difference. And to give you another example, up in Cairns, Liz Jackson, I'm sure well known to many of you, an obstetrician gynecologist, has for some time now been using My Health Record to fill the gap of absence in relation to care planning. She puts up her antenatal notes into the My Health Record. The GP is able, through an event summary, the GP is able to modify that through another event summary. The staff in the hospital are able to prepare in advance when somebody's coming in for labour, and particularly important when there's complications arising. And for her, she says it's been a game changer and simply allows her team, in her words, to act together to deliver high quality care. So these are small things, but they're really beginning to happen. And just one final example. In the Royal Perth Hospital, perhaps digital health may in the end come to be seen as truly transformational for people in remote rural Australia, above all other communities in this country. But here we have Royal Perth, long history in which Indigenous Aboriginal people discharged from hospital, long trek home, sometimes literally weeks to get back to their communities up north, lose the discharge summary even if they were given one in the first place, end up forgetting which medicines they're meant to take, seeing GPs who don't know their history, and unfortunately being given the wrong medicines and being then readmitted back into the hospital. And so profound was this problem of readmission, and so inhumane was the experience for those affected, that the Royal Perth set up a scheme called the Lighthouse Project, which now uses My Health Record to promote awareness of the discharge summary and has had great success in reducing unnecessary readmission into hospital for those very vulnerable people. So just some examples of the way in which already, before we get too focused on how much more we have to do, actually digital services are being deployed right here, right now, by clinical leaders across Australia. In 2017, the governments of Australia agreed the new National Digital Health Strategy to support that humanity, that patient-centred care for Australia. And they did so because you, the AMA, and many other clinical and consumer peaks told them that people want better access to their own information as consumers of healthcare. And whether that's through apps or through the My Health Record or in other ways, people want to take more control of their own health destiny, want to manage their well-being better. And we've seen already significant public involvement with My Health Record since opt-out occurred, but also an increasing demand for additional services. So you'll see over the course of the next 12 months, the agency working with partners in Western Australia, for example, to develop a whole new pathway around end-of-life care, supporting people to upload our advanced care directives into the My Health Record, working with ambulance and other services, emergency services and hospitals to be part of the broader network who able to receive information of those choices around preference for end-of-life treatment. You'll see in Queensland the digitisation of the pregnancy record for the first time. So that's another national programme starting here to support mothers in advance of birth manage their health and well-being and that of their children better than they currently are able to do so at the moment. Above all, what the governments were told when they endorsed the National Digital Health Strategy was that people want trust, that nothing should be done to compromise the sanctity of the confidentiality of the clinical encounter. And I reflect on that because we've just in Australia been through a really important debate about privacy and confidentiality in the context of the My Health Record opt-out programme, and the government listened to that, legislated, provided some additional protections. But I think one of the really important lessons that countries around the world have learnt, perhaps we had a taste of that last year, is the importance of social licence in taking forward the opportunities of technology in healthcare. So My Health Record did move to opt-out on February the 22nd. Records were created for more than 90% of Australians. I just wanted to give you a couple of updates around what that means in practice. So today, we are seeing, as you'd expect, unprecedented levels of engagement from the clinical community with the My Health Record. There has been a massive increase in the availability of clinical content in My Health Record over the last few months as well. So just as an example, now well over 85% of community pharmacies are registered to upload into the My Health Record from pretty much a standing start 12, 15 months ago. 60% are already uploading dispensed medicines information into the My Health Record. And we can see anecdotally, and of course we're measuring this in more specific, evaluated ways moving forwards, but we can see anecdotally that this is already, as the case in Bowral, describes having a significant impact on the ability of clinicians to reconcile people's medicines. Pathology, public, radiology, public, that's basically ubiquitously now being uploaded into the MyHealth Record. Private radiology, you'll see some significant announcements about enhancements to availability of that content very shortly. But broadly, by the end of this calendar year, MyHealth Record will contain comprehensive coverage of community pharmacy, of public and private pathology, radiology, discharge summaries from both public and private hospitals. It is a game changer, and of course I would say that, but I think we're going to see very rapid changes in the way clinicians are able to support people just through simple access to information of this kind. And just one final point on the MyHealth Record is that a new functionality, the pharmacy shared medicines list, will be uploaded, the Webster pack, so people can see into the medicines. In the end, as I said at the beginning, the implementation of the strategy and its other priorities, secure messaging among them, interoperability, is about supporting the humanity of clinical practice, putting the foundations in place, and ending the tyranny of the fax machine and paper-based healthcare. And I'd just like to leave you with one final reflection of the real world beginning to take advantage of these digital services. So we had the floods in Townsville recently, and a real challenge to emergency services there to support people, particularly with access to medicines when they were necessary. And this is a quote from a pharmacist reported in the Australian Journal of Pharmacy just a couple of months ago. The biggest problem for pharmacists is people being cut off from their home pharmacies. So they're presenting at whatever pharmacies are open without much knowledge of their medicines and without their prescriptions. At the moment, MyHealth Record is absolutely shining. The doctors are loving it, the nurses are loving it. The traditional relationships between GPs and patients just don't exist at the moment. So everyone's trying to help each other, and MyHealth Record is able to provide a consistent medication profile. Thank you.
Thank you very much, Tim. That was an excellent address. Okay, it's morning tea time, and I have some messages before you leave the room. Anybody who wants to register for the soapbox on Sunday, could you please see Cindy at the front desk? And would you please bring with you to the next session, a policy session, your personal device, laptop, mobile, whatever it is you're going to use to vote for the policy motions. We will have to start the policy session right on time at 11. My apologies if you are a bit late. The session will begin at 11 o'clock because of the packed agenda today. Thank you, everybody. See you in 20 minutes.